So, hello, this is Ari Friedman. My name is Keith Marill, and we're going to give this talk today, likely underused, improving diagnostic tests in emergency medicine. Thanks for coming by. We'll go ahead and get started. And as I said, we have a handout that we have a sign-up sheet. We'll send it to you if you'd like one. The basic plan for the talk, we're going to talk about assessing a univariate diagnostic test. Univariate meaning you have one predictor and of course your outcome. And we'll talk about likelihood ratios. We're going to defer interval likelihood ratios to the end, time permitting, just because time is so tight. Ari will talk about likelihood ratios in the EM literature and how we maximize sensitivity and specificity, and what that means when studies, how often and what it means when studies and samples have 100% sensitivity or specificity. So there's a little bit of sort of basic groundwork and a little bit of more advanced stuff here. It's kind of a variety. We assume people have different levels of expertise coming in. So anatomy of a univariate diagnostic, dichotomous diagnostic test, 2x2 table, which presumably you've all seen. Note that sensitivity on the left, the blue circle on the left, deals with people who have disease. Probability of a positive test in people who have disease. Specificity deals with people who don't have disease. Okay? So if I measure sensitivity and specificity on the patients in my ED where a certain disease is very common, and then we go ahead and use that test in your ED where the disease is not so common, that's okay. Okay, because sensitivity, again, is only dealing with the people who have disease, and whether there's a lot of them or a few of them in my ED or your ED, it's generalizable, can be transferred. That's a little bit in contradistinction to positive and negative predictive value, which deal with people who both have and do not have disease. It crosses that vertical line there. So therefore, that's not as generalizable in the sense that if the pretest probability of disease, if the prevalence of disease in your ED is different than my ED, then your positive and negative predictive values would be different, even for the same test, one would predict. And it's also important because you can see that if an investigator were to study a test where there's a low prevalence of disease in their sample, so if you study a test that's very rare in your ED, then it will tend to have a high negative predictive value, really regardless of how good the test is, because there just aren't people with disease who are disease positive. That said, there are uses for positive and negative predictive value. For example, you might have a really good test, but apply it in your ED to a very rare disease. In that case, it could be a good test and have a good sensitivity and specificity, but even if you get a positive test, if the disease is very rare, it may not be so likely that the patient has disease. So it's not useless, but these are less generalizable metrics than sensitivity and specificity. That's really the point here. So the next step then is you can combine sensitivity and specificity to form likelihood ratios. Likelihood ratio positive, meaning if the test result is positive, or likelihood ratio negative if the test result is negative. The formulas are on the right here. And the point here is this allows you to use the kind of Bayesian principle, which we all do clinically anyhow, in the sense that you have a pretest likelihood of illness, of disease. You apply the test and the test result, positive or negative, and then you end up with a post-test. You adjust your likelihood of disease and end up with a post-test likelihood of disease. To be precise, we talk in terms of odds when we use this formula. Pretest odds of disease multiplied by the likelihood ratio, positive if your test is positive, negative if your test is negative, and get you a post-test odds of disease. The odds of disease and the probability of disease is the same information, just expressed in a different way. In our handout, we show you the formula. It's very straightforward. But for example, if you have a 50% probability of disease, 50-50 chance of disease, that's an odds of 1 to 1 or an odds of 1, and that corresponds to a probability of 50%. If you have a 66% probability of disease, then that corresponds to an odds of 2 to 1. There's 2 with disease for every 1 without. So you can interchange between odds and probability very easily as far as that goes. But the point here is that the likelihood ratio mirrors the clinical thinking where you have a prior or a pretest odds of disease, you get a test result, and then you alter your odds of disease to get a post-test odds of disease. I think we all do this in our heads many, many times for each patient as new information comes in, whether it be history, physical exam, lab test, imaging, what have you. And the key issue here is because the likelihood ratios are based on sensitivity and specificity, the likelihood ratios also are generalizable and are not dependent on the pretest probability of disease. And so what ends up happening is before you do the test, you have the blue circles of pretest odds of disease. You have a bunch of patients. You have a chance that the patient does or does not have disease. Then you apply your diagnostic test and likelihood ratio, and if the test is positive, then you end up with the green circles and a post-test odds of disease, or if the test is negative, the red circles and a post-test odds of disease for a negative test. So that's sort of the basic kind of Bayesian idea. And it's important to note that this is different than an odds ratio, and different in an important way. The odds ratio, which we commonly have in epidemiologic studies, is useful, but not as useful in the clinical sense that you can't take a pretest probability, apply the odds ratio, and get a post-test probability. The odds ratio that you have in epidemiology compares patients who test positive to patients who test negative. And in any given individual patient, they can only test one or the other, not both. So it's much less useful from the clinical point of view, though it is very useful epidemiologically, that being odds ratio in distinction to likelihood ratio. And one other point that I want to discuss with you is the idea of the ROC curve. So this is a study that two of the physicians in my department did a few years ago, Heidi Kimberly and Sasita Shah, looking at whether the optic nerve sheath diameter is correlated with opening pressure on LP. The basic idea being that can you use ultrasound and optic nerve sheath diameter to predict CSF pressure. So the raw data for the study is on the left, and the ROC curve is on the right. The ROC curve combines the sensitivity and specificity and gives one a sense for the overall utility of the test. So the greater the area under the curve, the AUC, the area under the curve, the better the test is. And the curve is defined by the raw data on the left. And the way the curve is defined is, first of all, you have whether you have disease or not, and that's the horizontal line. So opening pressure greater than 20 means you have disease. Opening pressure less than 20, don't have disease. And then you, the clinical investigator, choose the vertical line, which tells you whether you test positive or negative. And you have some choice there. We put the vertical line there at 5 millimeters, but it doesn't have to be at 5 millimeters. If it is at 5 millimeters, then you get the 4 boxes of your diagnostic test, as you see there, applied to the raw data in this particular case. And then that corresponds to the point on the ROC curve that's delineated there. If you choose different test thresholds, different cutoffs for what defines a positive test, then you fill out other points on the ROC curve. Okay? So the blue to the left, a test threshold of 4.5 millimeters means it's a more sensitive test. More people fall to the right, more people test positive, and then that moves you up on the ROC curve to the shoulder up here. in general, in emergency medicine, we want to be up high where sensitivity is very high at the expense of specificity. And then finally, note that because the ROC curve is sensitivity versus 1 minus specificity, you can see the likelihood ratios for that test and threshold right on the ROC curve. The slope from the bottom left to your point for the threshold you choose, in this case we chose 5 millimeters, that's the LR positive. The positive likelihood ratio is that slope, and the LR negative is the other slope from the point to the upper right of the curve. So again, what we're aiming for is to define a test and a test threshold that has a very shallow LR negative, that has a very shallow LR negative, and thus will serve to lower the odds of disease if the patient tests negative. You want to choose up high on the shoulder and lower the odds of disease, particularly in emergency medicine where we're dealing with life-threatening illness. Now, Ari's going to go ahead and talk about these likelihood ratios within the EM literature.
All right, this is working? Good. I'm a pacer, so I'm going to come down and pace. But so that's like a lot of information to digest all at once. And I think, you know, it kind of speaks to the variety of multiple levels here. So who here has heard of a likelihood ratio before today? Okay, good. So there are, you know, a few key take-homes from this, right? One is that likelihood ratios, like sensitivity and specificity, don't kind of embed the population prevalence, so they're more translatable across settings, right? So therefore, and then also that likelihood ratios kind of mirror how we think about it clinically, right? So this is like the PE example that we do every day as emergency clinicians, where if you think they have a really, you talk to the patient, you think they have a really, really low pretest probability of having a PE, you don't even kind of consider it. If you think they have kind of an intermediate probability, then you're doing dimers or perks and things like that. And if you think they have a really high probability, then a dimer is just, you know, the negative likelihood ratio of a dimer is just not good enough. It's not going to produce good enough post-test probability, and so you're just going to CTA them, right? So given that, and then there's another issue which hasn't even yet been addressed, which is how uncertain are we about what the likelihood ratio from studies even is, right? So we sought to understand how emergency medicine diagnostic studies are using these various statistics, hypothesizing that the likelihood ratio was likely underused, and that confidence intervals around likelihood ratios, which turn out to be a little bit hard to calculate when you have really, really highly sensitive tests, which is mostly what we're aiming for in emergency medicine, are going to be even further underused. So what we did is we basically took the top 20 emergency medicine journals, so that's most emergency medicine journals. We randomly sampled articles from them. So we have 124 articles that are representative of the population of diagnostic studies in emergency medicine. And then we categorize them by hand. So we have 2x2 tables that we extracted from every single diagnostic study in the emergency medicine literature from this sample. And we calculate sensitivities and specificities, and we see what the paper reports. Do they report a sensitivity and a specificity? Do they report positive predictive value, negative predictive value? Do they report likelihood ratios? And are there confidence intervals that they report around these measurements, right? So what we found is of the 124 articles, 37 report a likelihood ratio, essentially. Like essentially 100% report, or almost 100%, high 90s, report sensitivity and specificity, right? So only 30% of emergency medicine diagnostic studies in the last, it was 5 years? 5 years? More, yeah. Report a likelihood ratio at all. So it does seem that this really useful thing that, you know, if you look at guidelines on how to report diagnostic studies, all suggest should be reported as essentially the primary measure reported from these studies, is significantly underreported in the emergency medicine literature. So one of our goals for today is to kind of plant that in the back of your head, that if you're doing a diagnostic study, if you're interpreting a diagnostic study, certainly if you're reviewing for a journal and trying to decide whether this should be published or not, it's an easy ask to come back to the authors and say, please report a likelihood ratio and a confidence interval around that, because they've got the data already. They can just calculate one more number. All right. So then we thought, it's likely in the emergency medicine literature that people are aiming for really, really, really highly sensitive studies, right? So if you're designing a test in the emergency medicine literature, you're aiming for, to design the next Perk rule or be the next Ian Steele, you're going to aim for something that's highly sensitive. And the reason that, well, anyway, and we find that that's indeed the case, right? So 24 of the 124 articles, so about 20%, have either 100% sensitivity or 100% specificity at like exactly 100%, not like 99.9, but 100% sensitivity or specificity. So that's sort of this bar of papers right there that have 100% sensitivity and specificity. And you can see, indeed, everybody's aiming for really highly sensitive studies, which makes sense. The reason why that matters is that calculating a likelihood ratio turns out to be a divide by zero problem, if you remember your high school math, where you got a zero on the bottom and it just turns into sort of infinity and all blows up. And so you can't sort of calculate a confidence interval using sort of the traditional way of doing it. So Keith and I and some colleagues designed sort of a better method for doing this and made some really super easy to use software that will do that, that I'll show you in a second. The other reason why studies that have 100% sensitivity and specificity matter is that we tend to, when you see a study that has 100% sensitivity, you tend to think it's 100%, right? It's just one of those numbers that's like almost too salient. And it turns out that if you see a study that has 100% sensitivity versus a study that has 99% sensitivity, you should actually trust the study with 99% sensitivity, like the test with 99% sensitivity more. And the reason for that is, if you could imagine, if you did a study with 10,000 people, right? That study will not have 100%, exactly 100% sensitivity, right? Whereas if you do a study with 30 people, just by chance, those 30 people may all turn out to, 30 people with disease may all turn out to have test positive characteristics, right? So studies, so I don't know if you have a laser pointer here, but the studies that are 100% sensitive, exactly 100% sensitive on average, have sort of half the sample size of studies that are like 99% sensitive, that are not 100% sensitive. Okay. So then the next question is, sort of using this method that Keith and I created, can you calculate confidence intervals around it, right? So it turns out if if it's 100% sensitive, your negative likelihood ratio will be 0. That's just the basic math of it. And then how high up does the rest of the confidence interval extend, right? So of these 120, at this point, 100 studies, there were 6 that calculated confidence intervals around their likelihood ratios. Of those 6 studies, when you use our cool method, the confidence interval gets 40% narrower, right? So if, so we actually should be more confident in these studies than the existing method implies. And this is like one of the free wins in statistics, right? So usually the better method makes your confidence interval bigger and you never want to use it, but this is like a free win. Okay. And then the final kind of takeaway here is, how do you use this? So there's some free statistical software called R. You can download it. If you search for the letter R and statistics or R and programming, it'll be the first hit. You can download that, and then you can type in, just copy these commands that are in the handout. If you sign up for the thing, we'll send it to you. And then you type in this third command, just copy it exactly as is, and include the 4 numbers from your 2x2 table. And it will tell you, even if your study has 100% sensitivity or specificity, it will tell you the positive likelihood ratio, the negative likelihood ratio, and the confidence intervals around those likelihood ratios. There's also a way, which I don't think we included in the handout, but also included in our software package, which will calculate like the sensitivity and the specificity and all the other numbers you might want for your study. So kind of going back, likelihood ratios are a good thing. You should, if you're doing diagnostic studies, be reporting them as much as possible. If you're interpreting diagnostic studies or thinking about them, you should be looking for likelihood ratios. You can always calculate a likelihood ratio from a paper, even if the paper doesn't report it, right? You can just go back to the numbers they give you and calculate a 2x2 table. And they mirror how we think clinically. And there's this easy software package that will help you calculate them. Yeah. we have time for questions?
Questions? Actually, I just want to add two comments. For those of you who haven't, who has not used R in this room? Not used R. So fair amount. So you know, Ari learned R shortly after birth, but I didn't. So don't be afraid. It's actually incredibly easy. Well, I won't say incredibly, but it's not difficult to download the program, and it pretty much sets itself up. And then all you simply do is grab the packages from the R repository website, and literally the only command you need to put in to do this is what you see there, those 3 lines with the arrows. So it's actually very simple. Do not be intimidated by that. And the only other thing I'll say is actually the 4 numbers that you see there are, it's actually, if you look at the 2x2 table, just to be precise, just let's see. So if you look at the 2x2 table here, the 4 numbers that you're putting in are actually A and A plus B, not B, and C plus D, actually. Just to be precise. Okay, so questions? If there aren't questions...
We can also force some questions. Okay, there's a question.
I think you might have say that again because it's prevalence versus total need.
Yeah, I said it wrong. You're right. It's A and then A plus C and D and B plus D. Pardon me. And when you use the program, it tells you. It tells you what you need to put in. Sorry about that. So what you would put in on those 4 numbers would be the first number is A, the second number is A plus C on the table, D, and B plus D. And the documentation tells you that. It's a good point.
So here's, oh yeah, keep on.
Like prior to a package like this, was there any way to do this, or what were the workarounds that were being done?
Yeah, it's really interesting. While I haven't used R for decades, I have kind of wrestled with this problem because I've had studies that have had 100% samples, sensitivity samples for really going back into the late 90s. And so I used StatsAct, which is, considered state-of-the-art software. And it was obvious that the estimate was substantially too high. And they use a variety of Taylor series methods. What we use is a bootstrapping method. What has been used in the past is Taylor series methods. And their estimate was way too high. Since then, they've actually improved it. And what you see here is their improved version. So it's better, but it's still too high compared to a more precise method. And the other thing to keep aware of is with SAS, there's 2 ways to do it. And one way is way off, and one way is pretty good. And it's the score method is the default SAS method is in general way too high. The confidence interval widths are way too high. The SAS score method is a better method. And if it makes you wonder, like, gosh, what do you mean? It's a 95% confidence interval, it's supposed to be 95%. Statistics is not quite as clear and clean as you might think it is, even among statisticians. So the fact that there's differences among different reasonable methods or the best methods out there is sort of well known. The R score method is a score package that you can also download in R, and somebody has written to use the score method, and that's also aims a little high, but it's another way to do it.
Ours is better. That's the other paper, which is in Statistical Methods in Medical Research, which nobody here will ever read, myself included. Only Keith probably has. So it's, but yeah, I mean, we in that paper we show like via bootstrapping, or like a simulation approach, a million different ways that our method consistently has 95% coverage, which means it's better, and the confidence interval is narrow, which means your study is more likely to attain the magical star next to your number. Yeah.
And again, the handout, if you ask for it, the handout has references, a variety of them.
There was a question.
You just answered my question. It was the citation, if we're going to use this method.
Yeah, the other thing is that R has actually a citation function, so you can just say, like the package we wrote is called boot.lr, and you can say citation parentheses boot.lr, and it will give you the citation. So you can always do it that way. And then, we'll publish this in the emergency medicine literature at some point soon, hopefully. The sort of survey of the emergency medicine literature and the relative use of different kinds of diagnostic study summary statistics, and then that'll be citable too.
So the overall point is, when doing a study of diagnostic tests, you really ought to include a likelihood ratio, positive and negative, unless there's a reason not to. And if you're going to include a metric, then you should have the 95% confidence interval as well. There's a variety of ways to obtain that, and this is one way that we think is good among others.
Cool. We should probably end, we can talk later, but thanks everyone for coming. Really appreciate it, and hopefully you learned something.